Yeah.
Fair, people are like that with their dogs too.
Oh,
it's
yeah.
just whatever.
Yes.
There's that type of person for just about anything.
No, I'm like touch my dog and figure out what's happening.
Yeah, it's like, why would you do that for?
I had to pay $100 today for them to tell me my dog had allergies.
Yeah. And it's like I get certain aspects of the vet industry. Well, I took my dogs to get their final checkup after their treatments. I took them back to their vet, which we're not going to keep going to, but it was, for those of you who care, that Yukon West, the one that's on, yes, they have a reputation. So they're hella busy all the time. And the people that work there long-term all have a jaded ass attitude. Yeah, it's horrible. So it is. So anyways, that's where they were, and it's fine. I understand to see a lot of cases and they're probably good at like the actual medical side of things. But my dog was, I guess, scared. My little dog was scared and bit one of the people. And they were like, your dog bit one of the techs. Like that, like I was there to have stopped it and I just let it. I'm like, do you know what industry you're working in? Like,
it happens.
I'm just like, yep, I bet it did. I bet it did. Yeah, so like you can't bring it back in without a muzzle. And I'm like, that's fine, but you can say it differently if you want to, just saying. I wasn't there for it, or I probably would have. It was my husband, who's way nicer than I am. Yeah.
No, I asked about that. Well, that might be the clinic I worked for a month. And the way they did things just didn't sit right.
Yeah.
Like it never clicked. Like I could never do anything right. And Tony was just on my ass about everything.
The best clinic I'm working for now is 405 Vet.
Oh, I love that. That's where I go.
Well, they're honestly like on Northwest 150th Street. Yeah, and that's where I work. And like technically my schedule on Tuesday says I'm there until 6. But as soon as they know that I will leave early on Tuesdays at 5, so I can get to class. And then just like, that's okay. You know, just as a reminder, kind of tell us.
I like for that for leaving early. Tuesdays and Thursdays, I told them, I said, I have class, I have to leave. And then 2 weeks after class started, she wrote me up for leaving early. No, I told you. Like,
yeah,
I'm serious.
And like I said, it's just how their scheduling system works. But yeah, 405 Vet is honestly like the best, like so far that I've been to. And like,
Clinic's okay. I work at the one in Rio. So funny story. I thought this bag is my school. I used it as a sweet shirt. So I'm a big Coleman fan. Not like just to music. Personally, I have no idea. But I'm just like
Christy, I have your notebook. It's yours, right? Like, did you lose yours?
Is it green? Oh, yeah.
Well, it's one with has stickers on the front of it.
Yeah.
Yeah, does that sound right? Yeah, like lots of stickers. Yeah. Okay. I have it somewhere. It's either in my office or in the lab. I'm not sure where I had left it, but I have it. So if you're not in any like serious like panic for it, I'll get it to you before we get into the lab exam. But yeah, okay. Okay.
Like a title to mess hilarious.
Seems like it, yeah.
Yeah, that's fine. I didn't really look at it. I just like was trying to figure out whose it was. You're all right.
Oh, yes.
Okay.
I also like them. Because it says.
Let me make sure that I have sound on this. Yes. Yes.
That's not what that. She explained to me what it meant.
I was I need a paper.
So I can't wear this to school.
I use like so many notebooks this semester.
Okay, except that he is actually talking about custom paper with it. So
so I don't know how I feel about that. Okay, yeah, no, that'd be good. That'd be good.
like the Bradley name is
All right, so be sure if you guys haven't already, be sure that you sign in because I actually have the sign-in sheet. I might have brought it to you guys last time. I did, right? You were like the one class I didn't forget. But yeah, it's over there, so don't forget to sign in. Because like after we're done in here, we'll probably just go like straight up stairs. I've already got everything like turned on and set up and everything. So all I'm going to do is like give you the little spiel of like, you know, don't touch the microscope, or if you have this problem, tell this, or whatever it is, you know, the rules. But aside from that, for the, because I know that's what everybody's really thinking about is the lab midterm. I get it. Aside from that, compared to when we have our lecture exams, and I do give you guys those study sheet outlines with information on them that have the stuff that you're supposed to know for the exam, but then I'm sure finding a way through that and making your own notes relating to that, that's that thing. But then I gave you these study sheets that I just made with the nice, colorful, you know, and pictures for our lab stuff. How do you guys feel about those study sheets so far?
Super helpful.
Really good, really helpful. That verifies everything, because typically people who have taken my class in the past would tell you, my first lab exam is usually the worst score of all the exams all over. And I don't know why, but it is. On average, my lab exams, and I feel like they typically, to me, the questions are easier. And I guess it's one of those things where like, when you take it, it seems awful. And then you go back and hear like what the answer is and why. And you're like, that's another one of those like, well, shit, of course that's the answer. But usually 60 is the average. Okay. Just so that we're aware of this. My Tuesday morning class, just before you guys took this test, an average of 78. And I am 100% sure that it's those study sheets, because they make it clear and obvious where the information is. You can see it. It's not all just black and white words. How are you supposed to, when I see shit like that outline, even my brain wants to shut down and like be overwhelmed by it. So I hope that that's helpful. But at the same time, one of the things I've talked about with Dr. Rhodes, and why I'm even bringing this up, is I'm glad that those notes help you guys. But of course, I wish I could just give you notes like that all the time. And even if I did, and it would help your grade, and that'd be nice, y'all aren't going to get that in every class going forward. And I'm sure people who are in the first semester of nursing school will tell you, you need to know how to take your notes on your own, because in nursing school, they are not going to hold your hand. They will not do things like this for you. Everybody in nursing school will tell you that. And I don't care if you're going to nursing school or wherever. Typically from here, it gets harder, not easier. And I'm being serious. And the only reason I'm saying that is I'm happy to help you guys and everything. But if you liked those handouts for the lab, then I challenge you to try to make those as we go for the chapters, as well as maybe for the lab. As you know, I might make another one for the final for the lab, but I don't want to keep making them and giving them to you for the lecture. I know I gave you the one, but like, I think it'd be good for everybody if we could work on making them for ourselves, the ones that work for you, because the sooner you can get that down here, the idea is to be able to take that with you going forward. That's what I really want for you guys, because I think that a lot of people's struggles really are in taking notes and making them effective, so you don't waste your time studying shit that you don't need to know and just being overwhelmed by it. So that's my 2 cents, okay? And I think that the proof is in the freaking pudding, man. 78, it's the same freaking tests that I've been given. The same test that people got the 60s on. I'm not doing anything different except that study sheet. That was the only thing. I've never done that before. So proof in the pudding, man. Make your own. If you can make your own, you are set for life, man. And I guess that just shows, like, because I just do that. I'm just like, yeah, here's some study notes. Isn't it pretty? And I can just crop them out for you. Clearly, I have practice in doing this, but now it's your turn to get practice in doing it. If you guys ever are working on something like that, and you do want to start working on making your own notes like that, and you're really like struggling with it, just email me like your examples, and I'll try to help you. I've actually in the process of helping quite a lot of people work on stuff. And I want you guys to succeed from here, not just in here. Okay, so let's do this one. Chapter 12, this one's only like 60 something slides, so it's not as bad as the other one. If the other one wasn't so bad, it was just a lot. Okay, so antimicrobial drugs. These are drugs that are anti-microbe. So drugs that are going to kill any microbe, any germ, not just bacteria. Microbial, that's going to be all the microbes, okay? So that's a very blanket term. And of course, so these are the traits you would want in an antimicrobial drug if you're treating somebody's microbial infection. We'll come to the top one in just a second, but microbicidal rather than static. That should be obvious. Obviously, you want it to kill. Soluble in body fluids, again, another obvious. Be potent enough to act like like you want it to be able to do its job without the body getting rid of it. That's what I'm trying to say. So it hangs around long enough to do its job. And then slow or non-existent resistance developing. So that's a nice dream, right? Wouldn't it be nice if we had a perfect drug? Oh, so I was going to come back to the top one. Toxic to the microbe, but non-toxic to the host. Easy concept. We want to kill the bad guy without hurting the patient. This has a term for it, and we're going to come back to that term and have it up on the screen and everything nice and pretty for you in a little bit, but it's called selective toxicity. It's toxic, but we're selecting to be toxic to the bad guy, and preferably not to the patient. Whatever, if it's a human or otherwise, don't matter. Okay, the ideal antimicrobial, again, going on, should help out the host defenses. The ideal situation, you would still have some immunity that could build up while you're helping to treat this. Be active in tissues and body fluids for a while, delivered to the site of infection. This is a bigger issue than we would realize. And then shouldn't disrupt our normal body functions or cause allergies or anything. Predispose us to other infections, stuff like that. Obviously, a lot of these things you can check off for most of our antibiotics, but most of the ones we even know of, we know don't fill all of these boxes. Unfortunately, it's just how it goes. So readily delivered to the site of infection, you see if an antibiotic can't get to the target area, it can't get there if the blood can't get there, for example. So why would that be an issue? If you guys have ever seen anybody who has diabetes, especially type 2 diabetes, who is not managing it well, you've maybe known somebody like this, and you can tell sometimes when it's bad enough that they don't have good circulation in their extremities, especially their feet. Like purpley or even red like feet, because they're not getting good blood circulation through the area. And this is where you have people like stubbing their toes on things because they have diabetes and they're not managing it well. And having issues with your blood sugar can make you not as well oriented, not able to control body movements and things. It's small little things, but can make you more likely to trip on something, make you a little bit more unstable, more likely to freaking stub your toe on the corner of your, coffee table. And they do. And then get an open wound, or they go out in their backyard without shoes on and, step on something, or even get like one of those stickers. My yard is full of those stickers, you guys. My first year having a yard of my own. So I didn't understand about it. It is so many stickers. It's the worst thing. I can't even like go out in it without like actual full shoes on. So I know we're going to treat the freaking yard like ASAP and deal with that. But anyways, you get any sort of opening whatsoever. And now we have a wound where bacteria are going to grow. That person goes to the doctor probably late because, hey, if they're not good about taking care of their diabetes, they're probably not good about going to the doctor regularly. So they finally get this sore that's getting to the point they can't manage it. They have to go to the doctor. The doctor gives them antibiotics. And because they have diabetes and have poor blood flow to the area, the antibiotic can't get there. And they'll try this antibiotic and try to put like tinctures and crap on the outside to try to get from both sides. And it isn't working and the infection is spreading. And then ultimately what you have to do is amputate. And then the idea is, where should we amputate from or to? If they're just got the infection in their toe, do we just take the toe? If they have poor circulation in the whole foot, what if we cut off the toe and now we have this open wound that's going to have to try to heal? How is it going to heal properly if it can't have the body taking care of those areas? If we can't give them, you go get surgery. If you had something removed off of your body, they'd give you antibiotics to prevent you from getting the infection. Yeah. Try it if you remove it from somebody who already antibiotics doesn't work on because their blood doesn't get there. So that's where you have to think about that. That's why one little toe bump can lead to having an amputation to right below the knee very quickly. And if you think I am exaggerating about this, go to Southwest and stay there for a day and see how many legs they get sent in their pathology department that day. And I'm telling you, multiple a day. I worked in the lab, so I know. They would run out of space of where they could store the legs sometimes and store them in our refrigerator. Like, no shit. So feet, legs, whatever. It's usually feet and legs, usually not really the arms and stuff. So this is like way more serious than we probably realize, especially in places like Oklahoma, where the obesity rate is higher than like it might be in, say, California or something. So, and especially if you're looking at a place of lower income, like the areas around Southwest Integris. So pretty serious issue. But yeah, what do you do if you can't get that antibiotic there? And that's what the question is. So we have some terms that we want to be aware of when we're talking about our antimicrobials in general. Prophylaxis, if you've ever heard of a prophylactic, most people talk about it in terms of preventing babies. So prophylactics to prevent pregnancy are going to be things like condoms and birth control pills and stuff. It just prevents. So you take antibiotics before you go into your surgery to prevent getting an infection. Even if it's a big thing, like having your hip replaced, you might take antibiotics beforehand. So we have also antimicrobial chemotherapy. This is literally anytime that you get prescribed an antibiotic for something. You had a sinus infection and you went to the doctor and they gave you they gave you some antibiotic. I don't even know what, amoxicillin. That's antimicrobial chemotherapy. Chemotherapy is just chemical therapy. If you're taking a drug, that's a chemical. If you're being given therapy by your doctor with it, okay? Any drug in your body to treat anything will be called chemotherapy. It's just we only see the term used in the context of cancer treatments. So I don't know, but it's antimicrobial chemotherapy. It's just fancy word for it. Antimicrobial, again, that's our blanket term for all microbes, antimicrobial. And then antibiotic, if you hear that one, see the B in antibiotic, you see that, and you should be thinking bacteria, okay? Antibiotics only treat bacteria, nothing else. Okay, so a lot of our antibiotics come from nature. They're produced by other bacteria or fungi, and we know that because penicillin, most of us know that it came from mold. It was just observed that the mold would grow and bacteria wouldn't grow anywhere near it. And so, research, and then they found out here's this drug that it makes. Well, it wasn't really a drug at the time, this chemical. And we were able to utilize that for, getting rid of bacteria. So that was penicillin. It was the first antibiotic that we had. And it came just naturally from a fungus. And there's bacteria that make their own to fight off other bacteria as well. But we have also drugs that came later that we just modified the natural guys, like let's say penicillin. We added on some extra groups to make it work better, chemical groups, whatever they are. And that makes like amoxicillin and stuff like that, because those aren't all natural. Penicillin was, and then everything was derived from that. I keep making this turn. I don't even need this. I can just set it down. It won't be a problem if I do that. So synthetic ones are the ones that we have ideas about how these drugs work, and now we'll just make one from scratch based on that. But these tend not to get across the membrane very well, the synthetic ones. Narrow spectrum, these will just target specific groups. I don't know, and then those speak for themselves. I don't know what else to say about it. Broad spectrum more broadly. We already said this about it being from normal things to inhibit things in the area. We've even already talked about this. I just said this. Yeah, synthetic ones are designer drugs based on our knowledge. All right, starting treatment. So your patient comes to you and has an infection. Here's what you need to do. You need to figure out the identity. What is it? You need to figure out the degree of its sensitivity to various drugs. Now that already might sound familiar to you because of the stuff that we've learned in lab about which assay was it, you guys remember? The Kirby-Bauer assay? Yeah, so we're gonna get to it. But the overall medical condition of the patient is important as well. Some people might be too frail for certain drugs that might have serious side effects. You might not want to push them on them. Can the patient handle it? So you want to figure out what the infection is first, and you want to do it ideally before you choose the drug. There are going to be patients that you will see that will be so serious, and you're pretty sure they have meningitis, and it's probably bacterial meningitis, or you don't even know yet. But if you suspect that it's meningitis, you should treat it like it is the worst bacterial meningitis that it is, because if it is and you don't treat it, that person could die before you even figure out what's causing it. So you pump antibiotics at them. And I mean, like maybe more than one. You'll just throw them out there and be like, okay, now we'll figure out what it is. At least they're getting some kind of treatment. But you know what it is? Back off with the other things that you don't need. Sometimes you'll do that first, but most of the time, in most situations, you want to figure out what it is first. And you'll do that by examining the various body samples that we already talked about in that other chapter, whatever it was with all the, I don't know, said get in and out and how it infects and all that. So, and we'll talk more about it in chapter, whatever it is, 18, the diagnostic chapter, which is like a really short chapter, by the way. Kirby Bauer, we know it. At least here's something that we know and we've been familiar with, and it was one of those that we can see pretty clearly in our minds. We know the zone of inhibition is that clearing area around the disc, and that is going to be smaller if it is more resistant and larger if it's more sensitive or susceptible. And you can use that information to determine like what concentration of drug they need, because at that edge of that circle is the concentration of drug, the minimum amount that you need to inhibit the growth. And it gets more concentrated the closer you get to that disc. We could do math for it, but we're not gonna because I hate it. So, but yes, so that we can determine not just what drug, but also maybe what concentration to use it at against the microbe that came from your patient exactly. We're not doing some sample you got from a tube, we're getting it from your patient. So you can develop something called an antibiogram, which is essentially several antibiotics tested against your patient's sample that you can say, okay, it's more susceptible to these cause less toxicity, maybe we use that one. Yeah, of course, you know this and what the ZOI is, measuring all the way across. Cool. The next picture, here we have this, and it's hard to see on this terrible projector, but this is the E-test. It's pretty much the same thing as the other one with the circles, but it's got the strip on it. And the strip has numbers on it, and you can't really tell what it does, trust me. And the top of the strip, where the E is where it's the most concentrated of drug on the strip. And then down lower on the strip, we have less and less and less drug. So you can see if you were looking at where that little arrow is coming off that line that's shooting out, there's an arrow pointing at that area where it kind of converges at the strip. That's that minimum concentration, and it tells you on the strip. So that's really convenient. So of course, these are going to be more popular if you have an idea of kind of where you're going to work, because you don't want to use like 1,000 of these, but you could start maybe with the discs and then pick a few and then do the strips if you needed. So the E tests, depending on what you're dealing with, are very useful for that, determining the concentration of the antibiotic that you might want to use. That is the minimum inhibitory concentration, MIC. All right, so that being the smallest amount that inhibits, so that we can figure out how to treat this patient with the least amount of antibiotic possible. And the reason you want to go with the least, yeah, because of toxicity, you want to avoid that, but also you want to avoid resistance. Because if that person, like let's say, doesn't adhere to a high dose, you just slam a high dose at them. Oh, let's just make sure we take care of it, high dose. And that person doesn't adhere well to their regimen, and they develop resistance. Now that thing is resistant to a higher concentration than would have been. And that's really bad, right? So you want to start with the lowest to avoid toxicity and to prevent too much resistance developing. Yeah, I don't know what else to say. So yeah, so let's say we figure out what drug seems to fall in that category. We found the one that is going to work and that we think maybe isn't going to be too toxic, which we'll talk a little bit about it more in a minute. But and then you give it to the patient and it just doesn't work. You gave it to them. It said this was supposed to work. You did the Kirby Bauer. Why isn't it helping the patient? So here are the three things that it could be. And it shouldn't be anything else but these if you did your job right. Number one, it can't get there, like the diabetics. Number two, it's resistant after all apparently. And yeah, so it's resistant. And essentially that just means you swabbed an area where you just didn't happen to pick up like the 2 microbes that were around that were resistant. And you might be thinking, okay, well, but if it was resistant, wouldn't they all be? All you need is one guy with a mutation, and he might not be resistant in, big scheme of things in that area that you swabbed. But if you treat that person with that antibiotic and kill off all the ones that weren't resistant, what's going to grow over? The ones that were. So you create more of a problem then. But that might be it. You didn't pick up a resistant guy. And then the third one is kind of a similar thing. It could be that there's more than one microbe that you picked up. Maybe the other microbe grows a little slower, but it's resistant. So you just didn't see that it was there, something like that. It can be complicated. So another thing we have to consider is the therapeutic index. And this is essentially the definition for this guy. The dose of drug where it becomes toxic to people. So you can take 0.2, you can take 0.3, but if you hit 0.5, people start seeing toxicity. That dose versus where it's effective. Still grows at 0.2, still grows at 0.3, but at 0.5, we have the MIC. It's the ideal concentration. Uh-oh, those match up. If we have 0.5 is where it's effective and 0.5 is where we see toxicity, that 1-to-1 ratio, that's bad. We want to avoid that because some of this toxicity is pretty serious. And of course, you could have other drug reactions that are going on in the patient as well. That could become the issue. So you want to have it be where, you know, the concentration of drug that you need to treat it hopefully is low, 0.2, right? And that where you start seeing toxicity in people is like 0.8. So you have that range that you can work within that is going to work. So that's the therapeutic window down there. So we want things that are less toxic, of course. And you have to consider the ratio of when it's toxic to when it's effective. All right, pre-existing medical conditions have to be considered. We kind of know this, like we just said with the diabetes. You also want to be sure of any allergies that they might have to certain classes of drugs, like penicillins or sulfas. Underlying liver or kidney disease. Now, this one I thought was kind of interesting that we specify these specifically, and I say so down in my little note area, but underlying liver and kidney disease, specifically those. Now, other thing gets to be, you know, heart disease, pop it in pre-existing condition, diabetes, pre-existing condition. But liver and kidney get their own category. If you know, if you've taken physiology, you can probably guess why they would have their own category. And it's just because your liver is what's going to be processing these drugs, these chemicals. So if they're toxic, if they, for example, inhibit DNA replication, because these are going to work kind of similar concept to how our control methods did. Remember, we already said that. Cell membrane, cell wall, protein, DNA. Okay. So if it affects DNA synthesis and it's getting processed by your liver just because that's what your liver does, it could affect DNA synthesis in your liver and cause damage in your liver. If you have cirrhosis, this could be a serious problem. Or if you have other liver disease. If you have kidney disease, this is an even more, I feel like even more serious issue because your kidneys can be pretty fast to just trash out on you. And it's like you might have just a little bit of issues with kidney issues and processing and stuff like that. This is why I shouldn't be playing with it. I had to always be touching something, my hair or a pen or something. That's why I used to have the freaking, yeah, that's why I had those up here, but I did not bring it today. So anyways, kidneys, they are filtering out your waste. We know that. So if your kidneys are filtering out your waste and your waste includes these toxic drugs, and as they're being filtered out, causing damage to your kidneys, and your kidneys filtering out your waste, now can't filter out other waste in your bloodstream, you can see how that's going to compound really quickly. You cause damage to your kidney with this drug. You can't remove the other waste. Now we're causing more damage to your kidney. You can't remove that waste, more damage to your kidney. It is one of those things where if you already have kidney disease and we give you a drug that's going to cause kidney damage, you can be in kidney failure within hours. It is serious. And I mean, it's the type of kidney failure where you might for the rest of your life end up on dialysis. So that is something you really need to be aware of if you're going into the medical field. This applies to especially elderly animals. Like if you're dealing with old dogs, these things apply to them too, very easily. Alrighty, infants, elderly, pregnant women, I feel like that speaks for itself. They're always a special case. Yeah, you always have to be aware of them and anything because they don't have functioning immune systems, or they're growing another person inside of them. That's a whole other thing to think about. If that drug stops, growth from happening. That might not be an issue for the elderly, but it would be for infants and pregnant women and their babies they're carrying. So yeah, so those are things we have to think about. Yes, obviously, this is synergistic and antagonistic effects of drugs. Drugs can interact. You might have some that help each other. You might have some that inhibit one another. So you have to be aware of that. That's called pharmacology. Pharmacists, literally like actual pharmacists, not the techs, pharmacists are specialized in this. That's why they go get a doctorate degree in this stuff. And they do actually have doctorate degrees, the doctor of pharmacy. So that's what they specialize in, is understanding how the drugs will work together. Antimicrobials will affect human microbiome just as much as they affect any of the other bacteria you're trying to treat. They're not any specially exempt from that. You need your microbiome, like we said, for our microbial antagonism. That's whenever we had our good guys all taking up all the stadium seats so that we don't have the bad guys able to sit down and grow and take up home. We need that biome there. So this is coming back to that statement that we made, that we want to kill the bad guy and not harm our patient, right? The very first thing that we said on the first slide, and that's called selective toxicity. I mentioned it, and it's a nice happy term that we have to actually know for this chapter. Selectively toxic. We want it to be toxic, but only to the bad guy. We're going to select bad guy for toxic, not us. And so the idea, if you want to be selectively toxic, you want to try to target things that are in the microbe that you don't have. So if we think about bacteria, we've already talked about with the control methods, we're going to have the same categories for this: cell wall, cell membrane, DNA, and protein, essentially. Cell wall, we don't have one. We not only flat out don't have one, but bacteria have peptidoglycan, which really is something that our body doesn't make. That's only found in bacteria. It's the only place in the whole world. So great, so we should do that. Let's target peptidoglycan. At least then we can kill all the bacteria. Maybe the gram negatives, right, might be a little less susceptible, because we learn they have less of dependence on their cell wall. But if you give them enough, most of them will bow down to it. And so we're great. We're going to go with the penicillins. They block the synthesis of the cell wall. There's going to be a problem with that. I'm sure you guys can imagine what that's going to be. Now, wouldn't it be nice if it just all worked that way? So here's our targets. Like we said, cell wall. And it jumps around different than what I expected to, but yeah, cell wall, nucleic acids, which includes DNA and RNA. So if we remember the processes to make those, replication and transcription, right? We block either of those. Those are our, nucleic acid synthesis pathways. Then we have protein synthesis. And the term for that is translation, right? Do you guys remember? Oh yeah, it already says on there, so I'm not even gonna ask yet. So obviously, if you're going to make proteins through translation, you need that machine called the ribosome. So most of these drugs are going to inhibit it from working. That's just how it works. And then interfering with cell membrane structure or function. We learned about that with surfactants, detergents, but these are going to work a little bit differently. They're usually going to be preventing the synthesis of it. And then we have inhibiting folic acid synthesis. Now, this one's an interesting one. Folic acid, if you guys have ever had a baby or know people that had a baby, or since you're going into nursing, you probably are going to learn about some of this stuff. They recommend that you take folate as part of, your vitamins, your prenatal vitamins. And that's because you're growing something in your body and making nerves and things like that. All that's going to end up healthier and better if you have enough folate in your diet, basically. That's the watered down version. But yeah, so you need it in your diet. You do not synthesize it. So instantly, we have found another pathway we can target. Because if we need it provided in our diet and don't synthesize it, let's block the pathways where other things do synthesize it. That's another thing we don't have. We get folate as in our diet, like we have said, that's a growth factor, right? So we have to have it supplied just like our other vitamins. And these bacteria, they make their own. So let's just make it so they can't. Let's screw that up. The drugs that affect that are the sulfas. Now you guys see where I'm going with these penicillins and these sulfas? Because yeah, in an ideal world, guys. Okay, so here's a nice little summary chart. It has way more antibiotics than you need to know. So if you go back to study where what antibiotic affects what by using a chart like this, I either make your own or just cross out the ones you don't need to know. Okay, but it's a good one that has picture, it points at whatever it's dealing with and whatever. I will ask those questions on the exam. Ask you like, what part of the cell do penicillins affect? Or which of the following affect cell wall synthesis? It's pretty common. That's usually like most of what I need you to know about these, okay? There's not much of anything else. Unless I state otherwise on the study sheet. So when you're taking antimicrobials at all, especially antibiotics is what we're mostly talking about, but at least 5% of people are going to have a side effect of some kind, at least. And we're talking about appreciable side effects, things like serious allergies developing, or some just serious effects, not like you felt a little bit upset stomach, okay? So direct damage to tissues through toxicity, allergic reactions, and disruption of the biota. You ever taken I think it's gonna come up later, but you ever taken an antibiotic for your urinary tract infection and then gotten a yeast infection as a result? Because you take the antibiotic for your UTI, it kills off all of the bacteria flora that were in the stadium seats. Some of them weren't bad guys. You kill off all of those, and then the yeast is sitting there like it was chilling, knitting or whatever, and then it looks up and it's like, oh, and it just goes rampant and grows everywhere. It doesn't know it's doing wrong, but it is. That was a disruption in the balance of your normal microbiota that allowed that to happen, right? We'll come back to that. It has its own term when stuff like that happens. All right, so people can become allergic to these drugs because our body can react to them as antigens. So we've seen antigen means anything your body can, your immune system specifically, can react to as foreign. It sees it as foreign, as not belonging here. So that's an antigen. And so drugs can be that. And most of us are probably thinking, since we've learned so much about proteins, that antigens should be proteins, and that isn't correct. And we'll learn more about that, of course, in chapters 15 and 16, because more about everything is always coming. So we have this, I don't even know what I was thinking there when I was getting ready to say that sentence. Anyway, so it can be an antigen, and your body can see even drugs, even metal as foreign, and say, okay, well, now we're going to attack it with our antibody. This protein recognizes whatever that thing is over there as foreign. So we're ready to kill it every time that we see it, even though it's not always bad. We're going to talk about why you do that to other blood types as well. We're going to talk about why you do that to your own body tissues as well when you have autoimmune diseases. That's all chapter 17. But anyways, so you see these and your body reacts to them. It could be the drug itself, or it could be something that it got turned into by your liver when it metabolizes it. Doesn't matter. You don't care either way because you'd be allergic to it. And the number one most likely drug you're going to get allergic to is not just penicillin, but psyllins, all of them. If you're allergic to penicillin, there ain't a psyllin on the block that you can take. Sucks. But that's out. So the cell wall thing is out for those people. The next most common, also very common, are sulfa drugs. So sulfonamides or sulfa drugs. And those are the guys that inhibit the folic acid synthesis pathway. You're unlikely to get allergic to some of the other guys, but those two, the ones you want to reach for the most are also the ones that you're most likely to be allergic to. Isn't that how life works? So that's how that'll go. All right, so you take that antibiotic for your UTI, you clear out your stadium seats, and now the yeast multiplies and takes over. That process is called superinfection. I know it, superinfection. And then if you take antibiotics, normal antibiotics, and the really hardy guys that have the endospores, because remember, Clostridium, they changed the name to Clostridioides. It used to be Clostridium. It doesn't matter, but Clostridium difficile is an endospore forming bacteria. It's an anaerobic endospore forming bacteria. So you take antibiotics and these guys can be, we already learned the endospores are the hardiest of them all, really hard to get rid of in general. So you take your antibiotic and you kill off everything in your gut for the most part. You cleared out those stadium seats and you got some C. diff hanging out because it is normal part of your biome sometimes in some people. And it'll just grow over super infection. And now you've got actual active C. diff infection. And that's how it happens. That's how it starts. So I went to go see my mom in Tulsa last weekend, which I already told you guys about that. But I went to go see her and I talked to her and whatever. And she has diverticulitis. And, you know, there's foods that you can't eat when you have that, or you aren't supposed to eat anyways, when you have it. And what it is you get inflammation in your intestines. And from the inflammation, you get these little pockets in your intestines that collect, you know, food, feces, undigested food, feces, bacteria. And they can become basically infected little pockets, almost like pus-filled little pockets all throughout little microscopic ones, but throughout your entire intestine, well, your colon mostly. And diverticulitis is actually pretty common, especially in aging folks. And I think you actually see it more in women than you do in men, but I'm not sure if that's 100% true. I feel like I mostly hear about it in women, and maybe the men just don't talk about it because they're tough. I don't know, but that's probably it. Yeah. Anyway, so but yes, you see this as people get older. You know, their intestines have been through a lot, I guess. So she's having issues with this, and she's been telling me she's having all these, like, you know, gut problems and whatever. And she's like, yeah, they put me on 2 antibiotics. Interesting. We're going to be hearing about both of them today. So we'll get to that later. But she has GI issues from her diverticulitis. And that reminded me about that. So anyways, here's my little sheet from all that crap that we just talked about that I wrote down of stuff that I would want to know from that stuff. Okay. You don't have to copy it down. This was just my notes, an example. And this was faster than the last time because when I made this, it was like 11 o'clock at night that I started all of this. So just, these are what notes probably would look like more for you guys too, if you're making notes what I'm saying, because I did not try to make it super pretty. I just kind of highlighted as I went so I could see it, which that sometimes helps more than anything, right? This is what were we dealing with as far as, nope, I did not do that. Stop. As far as spectrum. So we said narrow versus broad. You can clearly see that there's some on here that are more narrow, like the polymyxin and the tobramycin up there, versus like tetracyclines, which are like almost everything up there. But I'm not gonna make you remember which ones are more broad than the other, but just puts it in perspective. So now we're gonna go through these, you guys, and it's gonna go faster than you think. So that, you're welcome, okay? All right, so something you need to know about the cell wall. Drugs that affect the cell wall have this special, like say special ring. I've circled it on here. It's a square in the pictures. I'm not going to make you draw it or pick it out from pictures, okay? But it's called a beta-lactam ring. That's just the structure of it. Drugs that affect cell wall synthesis tend to have that, okay? So that includes the penicillins. Penicillin is the very first identified antibiotic, and it is going to affect cell wall synthesis. All psyllins do. So the psyllins, they have beta-lactam ring. They affect cell wall synthesis. Here's some other guys that do. There's crap written under these guys, but guess what? That's not on your study sheet, right? We look at Unit 3 study sheet. What chapter are we even looking at? This one, right? And we look here under chapter 12. It's like the 4th line down. We have cell wall, penicillins, and other beta-lactams, cephalosporins, and carbapenems. That's what you need to know about it. What am I going to ask you about cephalosporins or carbapenems? They might be in the list. I might say, which of the following affects the cell wall? And it might be blah, 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 cephalosporins. That's pretty much what you need to know about it. If I wanted you to know more, I would have put it on the study sheet, okay? So don't overthink it. Seriously, it'll save you so much trouble. Okay, yeah, it has other stuff on here if you're interested, okay? But there it is. Cephalosporins affect the cell wall synthesis, similar to penicillins. Carbapenem, if they are reaching for carbapenem, you're in trouble. It's the last line defense antibiotic. It is like the last line defense antibiotic. They don't go by groups of cell wall and then the membrane or something like that. There's just some drugs that are stronger, maybe have a higher toxicity, maybe work more. Carbapenem can be very, very toxic to your kidneys. So if they're already reaching for that and you're that sick and they're still like well, shit, we got to give him the carbapenem. It's going to work, but it's going to screw your kidneys up. Seriously. For example, I had a student just in my Tuesday morning. She was like, yes, my son, and she works at OU Children's. And she was even saying like her son had meningitis, but they didn't know that yet. He was just really sick. And they knew it was some sort of infection. And they were wanting to give him carbapenem. And they were like, we want to give him carbapenem. We think that that's going to take care of whatever this is, just knock it all out. But it's probably going to put him in dialysis for the rest of his life. And they told her that. And she was like, well, is there any way we can just like figure out something else? And they were able to diagnose it as a certain kind of bacterial meningitis, obviously not the worst one, or he would have probably been worse, dire straits, but it didn't present normally as meningitis typically will. And that's why it went that way. But anyways, lucky that they didn't give him that, because we're talking about that kid probably needing a kidney transplant later in life. That's how serious it is if they pull out the carbapenem. It's bad if you need it. That's saying that nothing else is working. Anyways, some other ones that you don't need to know, they weren't on the list, but I'm going to tell you about them anyways. First, the middle one, isoniazid, is used for treating tuberculosis. So interesting. I don't know. There's a story there. Bacitracin. So it's one of the ones you have to take for like freaking 9 months or whatever. Bacitracin is found in Neosporin, triple antibiotic creams like that, ointments, whatever. Bacitracin, neomycin, and polymyxin, actually. The other one we saw up there that was like super tiny at the top. And we'll get to that. And then vancomycin. Now, vancomycin is interesting that it affects the cell wall. Again, you're not going to get tested on it. Don't worry about it when you're studying. But most mycins are going to fall into the next category or the category after that. So it's usually doesn't fall there. But yeah, here's what you needed to get out of that. Wouldn't it be nice to just showed you this? Know this. But it wouldn't have been in any context. But if you guys were to draw something like this for yourself, if you're just taking notes, you probably would have context in your minds while you're drawing it, because you have to in order to draw the chart. So that's what I'm saying when you guys take your notes or whatever. Just thinking it through to make your notes and charts and whatever, it helps you remember it. All right, protein synthesis. Oh, yes, okay, good. I'm glad that it does this. Okay, protein synthesis. There's 2 groups within protein synthesis, okay? Aminoglycosides is one group, and I mean, it's a group, and then drugs fall under it, okay? So this group, okay, whatever, it's broad spectrum in general, and they all are gonna affect ribosomes. And the only one of all of them that you need to care about is tetracycline. We already saw how broad spectrum it was. So nice. So it affects the ribosome. You don't need to know how. It doesn't have that on your study sheet. But it does affect this step here. RNA to proteins, that's called translation, right? And the ribosome is the machine that accomplishes that. Will affect the other step later. But yeah, so there's other ones on here. I know you guys are probably looking at being like, what are the other ones? Because you're just so fascinated by this. But yes, the one underneath tetracycline, it took me not even joking, a year to say it, like in general. It's glycylcycline. Let me even just write it out for you so you understand the pain I was going through. Glycylcycline. Look at it. It was one of those ones where I used to just point that one. That was what I used to do. There's one of them on here, a sulfa, that I have trouble with just pronouncing it because of how my mouth and mind don't always work together. But tetracyclines, we already said it. They affect protein synthesis. They're pretty broad spectrum, but they're also pretty toxic. If you take tetracycline for a long enough period of time, and usually you take it for a while, it's broad spectrum, but you usually have to take it for a while. So it can create these gray bands on your teeth that never go away. So it's kind of unsightly, but if you need it, you need it. This is the second group. We said the aminoglycosides. That's a big group. We saw them all named, but the only one you have to care about in the aminoglycosides is tetracycline. Now we got the macrolides. The only ones you need to worry about with the macrolides, that's going to be the mycins. So I'm just telling you the mycins fall here, and I already told you that vancomycin isn't one of those. I'm not going to test you on it, but anything else that you see with mycin, I'm not going to include vancomycin anywhere on any of your choices on the test. No worries, okay? Anything else you see with mycin, protein synthesis, okay? azithromycin, clarithromycin. These are stuff you've probably heard of. All right, next we're on to the folic acid synthesis crap. Want to block the bacteria from making folic acid? Sounds great, as long as you're not allergic to sulfas. Here's our choices. This first one. Sulfasoxazole, there it is. Don't make me say it again, okay? That's the word. That one, it'll treat certain kinds of bacteria and certain kinds of protozoa, apparently, also. Whatever, but you don't really need to know that. You just need to know that it affects folic acid synthesis, okay? Then we know silver sulfadiazine. We actually brought this up in the other chapter, previous chapter, for treating burns, as antiseptic, right? But we can also look at it this way. So it is antibacterial. And then we have trimethoprim with sulfamethoxazole, which I don't know why that's easier for me to say than the first one, but it is. So we already know too that sulfamethoxazole and trimethoprim are going to come together because they did in our Carby-Bauer. That's our SXT. So, okay, so anything with sulf in the name, instantly folic acid inhibitor. I'm not going to ever put a sulfa something that's a made up name and have to pick out what the real sulfa is. Okay, that's BS. What I will do is have antibiotics, and you have to know which one is sulfa, which one is whatever. Okay. When we get back next week, I'm going to actually start having our Kahoot tests again beforehand, but I just wanted to walk through these notes a little bit more with you guys before we get into all that. Just because it's just a lot, right? You have lab BS, and I'm over it too. So sulfa, anything, immediately folic acid blocker. Okay. The only other one is that trimethoprim. It doesn't say sulfa anywhere on it. You can either remember that it always goes with the SXT, or what I do to remember, if I had it in a big old list, that metho makes it, maybe you can, I don't know, it just occurred to me that maybe you would think it was crystal meth. But either way you want to look at it, maybe if you see somebody who's on crystal meth and they are stinky people because they don't take care of themselves, or I think metho being methane, and that's a stinky thing, and sulfur obviously is stinky. So I'm putting the stinky things together, okay? So yeah, for what it's worth. So here we go. This is how this is going to go. You see how we're just trucking through these. Now we're at the DNA and RNA inhibitors. So we're either blocking replication and or transcription here. And it turns out that these guys work pretty generally. They block helicase, which you guys didn't have to learn about, and I'm not going to test you about it now, but just so you understand how they work. The helicase is the enzyme that unwinds the helix. So you have to unwind it first before you can open it up and start making your RNA copy or your other strand of DNA. Either way, you have to unwind it first. You block that, you can't do any of it. You can't open up your fork. So cool, so we're going to block that. These drugs are called fluoroquinolones. That's a name. You don't, I don't know what else to say. These guys, because they block helicase, we also have to use helicase in our cells. So that's a problem. We also have to make DNA and RNA in our cells, right? So this can be a problem. Of course, there's a little bit of difference there, but there's not a whole ton of leeway, especially if you are dealing with some higher doses of these guys. So these can be quite toxic sometimes to some people, and serious side effects can occur like seizures and brain disturbances, sometimes permanent. So these are the fluoroquinolones. That's a group. You guys remember how aminoglycosides was a group and we had tetracycline? This is fluoroquinolones, and we're going to have FLO stuff, fluoxetines actually. So I remember, because it's fluoro, so fluoro, even though there's a U, forget the U. And the sound of it, fluoro, we have fluoxetines, okay? Anything you ever see on the test, if it has fluoxetine after it, that is a fluoroquinolone. And it affects DNA and RNA synthesis. That's what you need to know about it. So of course, you guys are already seeing one that you are going to recognize. Ciprofloxacin. We even had this on our Carby-Bauer. And then we also have levofloxacin. There's other ones that'll fall under here, but that's the examples we have up here. If I see any, even if they're not on this board necessarily specifically, if it says floxacin on the test, you know where it goes, okay? Same thing with the psyllins, right? We know where they go. We get that. And the mycins, where they go. That's nice. At least you can put that and be aware of that. So turns out my mom, whenever she said that she was having all this diverticulitis issue and her doctors were concerned that she was having something else, she needed to be on these antibiotics. One of them was Cipro. So we're already on Cipro, which is already it's kind of broad spectrum and it can be a little toxic, but it's a pretty serious antibiotic. You got to be really wanting to use it. All right, so that's one of them. All right, moving on to the cell membranes. Now, this is polymyxins. We brought this up earlier. It's pretty narrow range. We said bacitracin, which affects the cell wall. We said the polymyxins now, the cell membranes. And the other one was neomycin. You guys remember which one that affects? Protein synthesis, okay? So that's going to be your triple antibiotic cream. You learned a thing today, yeah.
So basically it affects all different ways that they could continue.
They try to, yes, cover as much bases as they can. But there's an issue, of course, if you use it too much. That's why doctors say don't use it too much, because you could have, yeah, don't.
I don't know why, but.
Yeah, it's because of resistance. That's why, right? So it makes sense if we want to avoid resistance. It was so widely used, kind of like triclosan was, that's people just used it, but now we're trying to be more aware of resistance. So if you have like a cut that looks like it might be nasty, use it. But if you really don't think you need it and it'll heal on its own just fine, just clean it and put a Band-Aid on it. So, okay. But polymyxin is the only one you need to know in cell membrane. That's the story of it. All right. If you had biofilms, and you're not going to get tested over this one, but I feel like it's something to be kind of aware of at least. Obviously, if you have biofilms, you have layers of bacteria, and they kind of communicate with each other in the layers to let each other know how things are going, guys. And that's called quorum sensing. So when you're trying to treat a biofilm, you basically want to break up that communication. It's like, having an EMP, and now you can't call your troops in or whatever. So that's what's happening. We're making it so they can communicate. That's what daptomycin would do for us. And you're not getting tested over that one. But it's interesting. I think it is. So here's the ones you do need to know. And here's my little chart of it now that we've completed them. In case you can't tell, this is all of the antibiotics that you would need to know. There is one more that is not in the antibiotic category that we're going to mention later. And it's the other one that my mom was put on. Okay, so it comes in another category, which is not antibiotics, not bacteria. Okay, but it still can be used as one. So we'll get to that and you'll see what I mean in a minute. So yeah, she's on Cipro, which falls into that. Come on, dude, keep up with me. Falls into this area here. Really good arrow that I drew there. So anyways. Fungal infections. So our fungal guys. Antibacterial drugs like antibiotics, okay? They only act on bacteria, so they don't really usually treat fungo and stuff. Fungi are eukaryotic organisms just like us, so it becomes trickier because we're way more similar to their cells. So we have to treat it differently. A lot of times, if it affects them, it'll affect us. Cool, we told you that story about it. Here's the ones you need to know about. Amphotericin B and the azoles, okay? And that's it. But that azoles category is no small category. The azoles, ketoconazole is pretty commonly used for general fungal infections. Fluconazole, they use it for a little bit more specific things, but you'll often get either ketoconazole or fluconazole prescribed to you if you have like yeast infections and stuff, pretty commonly. Miconazole, we see this mostly associated with like over-the-counter yeast infection treatments like Monistat and things. And then clotrimazole, I just don't know very much about it, but again, antifungals. Yeah, is it? Athlete's foot? Yeah, makes sense. Yeah, I guess that's why I don't know. I haven't actually had to deal with it, but that makes sense.
Yeah, we're all kind of giving ourselves away.
It's super common. I mean, it's not like it's, yeah. So anyway, so there you go. That's something we're familiar with, at least so we know azoles. If you can at least remember that, oh, I've seen this was in this, and that was a fungal infection. Now you've got the azoles covered, okay? Azoles, fungal, not hard. Amphotericin B, you may have heard about it. It's for a little bit more hardcore. They're usually going to start with the azoles, and then if it's not quite doing it what it needs to, they'll give you amphotericin B. I only know this because I was started on ketoconazole for my sinus infection when I had the aspergillus ball or whatever in my sinuses, and it didn't work. So they put me on amphotericin B, but I didn't take it orally, you guys. I had to go to an apothecary, a compounding apothecary, which is a thing in the real modern times. And you go with your prescription to them, and they're also like pharmacists, but they like mix drugs for you. And it was a nasal spray of it. And I had to keep it in like the fridge and then spray it in my nose. It was cold and it was so awful. And it didn't work. I ended up having to have the freaking surgery anyways. So whatever. But now I have my story about amphotericin B. Maybe you'll remember it too. So now we're into the anti-protozoal and anti-helminthic drugs. The first ones I want to get into are the anti-malaria drugs. You can basically divide up the anti-protozoals into two categories: malaria and not malaria. Okay. So then there's really only two groups too. So the malaria ones, most of the major ones that were going to be used are going to be quinine based. Quinine is the original anti-malarial, and they've been using it for hundreds of years, if not more than that. It came from the bark of a tree. And, they used to make it as a tea to treat malaria, and people who lived in areas that were endemic way before, modern medicine existed. But as Britain decided that it needed to take over the world, and it tried to move into and take over India and countries in Africa as well, and they were being exposed to malaria. So they discovered about quinine, and they would mix it in their water, and they called it tonic water. Okay, sound familiar? It should. Okay. So quinine in their tonic water, it has a bitter taste, and people weren't drinking it because of bad tasting, right? So somebody came up with the bright idea to make a drink to mix with that like quinine crap, so that people will be more likely to drink it, so they'd not have the malaria and everything. And it's an alcoholic drink. Yes, it is. And it is made from juniper berries. Yes, it is, because that was cheap and readily available. You guys know what alcohol it is?
My favorite drink.
Gin.
Gin and tonic. Yeah.
Gin and tonic, y'all. That's where it came from. That's where gin came from. It was made specifically so people would drink their tonic water. So I don't know if it's the case. I haven't looked at the back of a tonic bottle in a while, but they used to include some quinine in it. Still, I guess, for like nostalgia's sake, but it's not enough to like really be useful. Also, here's the other thing of it. Quinine in larger quantities can cause blindness. So that's why we don't actually use it directly anymore for treating malaria. But we have these other drugs that are based off of it: chloroquine and primaquine. You notice the Quine, the quin, like quinine. So remember the quins, remember the gin and tonic story about the quinine, and anything that ends in Quine. It's usually, if I'm going to have it on a test and it's not directly quinine, it'll be chloroquine. Okay. All right, the next ones we have, going on to the other side of the protozoa, we have the malaria side with quinine and quinine-based drugs, and now we have the other protozoa drug, that is metronidazole. Now, this is the one azole that isn't fungal. Okay, so how I remember it, the difference, if I had a list of all the azoles, metronidazole, however you want to look at this, how I remember though, the metro to me is like the big city. This guy went to the big city because it's a bigger deal to be with the protozoas than it is with the fungi. I don't know, more advanced is how I see it. But yes, metronidazole is very commonly used, not just as an anti-protozoal medication, because it is pretty widely used. It says amoebicide, but they use it for a lot of the protozoa infections, but also as for treating anaerobic bacteria. It's like the #1 defense for strict anaerobes like Clostridium difficile. So when my mom told me that she was on ciprofloxacin and metronidazole, I knew exactly what bacteria those doctors thought she had. I knew exactly. I said, Mom, they think you have C. diff. And she was like, oh yeah, that's what they said. I was like, I bet that's what they said. So anyways, but yes, so metronidazole is like one of those frontline drugs for treating true like C. diff infections. They have to treat C. diff very aggressively because of the endospores, but also because it's very resistant. So they usually bombard it with at least 2 antibiotics. All right, so our anti-helminth drugs, I don't know much about the first two, but I am very familiar of hearing with the praziquantel and the ivermectin. Ivermectin is widely used to treat worm infections in pets. If you have heartworms, ivermectin. If you have, I don't know, booty worms, I don't know what other kind of worms they have. Any other kind of worms, but dogs can have a lot of worms, y'all. And I don't remember all the names of them, but they can have a lot of them. They eat crap, like actually. So yes, for funsies. So if you have dogs, you may be one of those people who gives them the chews every month for the heartworms. And those chews have ivermectin in them. And that's to keep any worms from breeding inside of your pup so that they don't get these worm infections. And it's great and it's fine. Ivermectin is fine in lower concentrations. It's really good prophylactically. When you have a worm infection, like heartworms in a dog, if you've ever seen pictures of like post-mortem pictures of like dog hearts of dogs that died from having heartworms that got so bad, you will see worms, like hella worms. And this is not a weird thing. Like you can see this at pretty much any freaking vet anywhere. Super common. People just don't know a lot of times that their dogs have heartworms and they don't know how to look for the signs and they just think their dog is fine and they're not treating it. And my dog's not gonna get heartworms. Nobody gets heartworms. Heartworms are really common. Really common. Treat your dog. Okay.
It's not be.
Yeah.
It's getting worse.
But now it's gotten a lot worse.
Yeah.
It's transmitted by mosquito bites. So if you have like the tick and flea ones that are the higher end drops or whatever that you put on your dogs and they can tolerate it because some dogs can't, but they can put those on your dog if they're going to spend time outside because they also can repel mosquitoes if you get the higher end ones. So they won't be as likely to get bitten, and give them their ivermectin chews so that they're like covered on both ends and you should be fine, right? However, stray dogs don't get that luxury. Stray dogs, you know, they're running around and they're not being treated. So they're getting bit by mosquitoes and whatever. And then they have their little heartworms and then somebody tries to rescue them. And then they take them to the vet and be like, oh, here's, you know, a little Fluffy. And I'm, you know, let's put him up for adoption. Isn't he so cute? Any rescue, bless their hearts if they take on a heartworm case, because nobody wants to deal with that when they can rescue another dog that doesn't have heartworms, because it's dedication. You're adopting a dog that you don't know and that you're not familiar with. The likelihood, if you guys have ever adopted a dog, you've probably gone through the phase, but if you're an adult and you know better, then you know if you wait through the phase, you'll be fine. Everybody has buyer's remorse. If you bought a car or a house or anything, the first couple of days you're with it, you're like, what the hell did I just do? And it's just like that with pets too, right? And so you get your pet and you know, you're already having the buyer's remorse and whatever. And these people are telling you that you're going to have to treat this dog for heartworms. And treating for heartworms is no joke. Oh, yeah. Treating heartworms is no joke. So your dog has heartworms. You have a dog that some rescue place somewhere, they just, you know, on a limb said, maybe people will adopt this dog. It has heartworms. Maybe there's somebody out there. I don't know. But usually they won't even take those dogs on.
We do, but you can hear the entire office sigh every single time.
Yeah, because you know nobody's going to take them. Nobody wants to deal with treating them because you have to be dedicated. Number one, you have to be dedicated. Number two, if you aren't lucky enough, then some places that are, you know, rescue places will fund the treatment for the heartworms, but they can't house them for the whole time that they're being treated, which would be usually at least a month of treatment. And when I say a month of treatment, when you treat heartworms, it's a month locked in your cage and you come out to go potty and then you go back in your cage for a month. It is hard. And people who are getting a new dog and want to have playtime with their kids and the dog and everything like that don't want to deal with that shit. They're not going to adopt that. And you tell them that okay, your dog has heartworms. You know, here's what you need to do. Just forget it. Another dog. I want a different one. That's most people, right? And so it takes real dedication, and you have to know kind of what you're getting into. Yeah, some places will fund it, but they just won't treat them themselves. They need to have somebody who is willing to actually house them, whether it's a foster that's that dedicated, which is unlikely, but a foster that's that dedicated, or somebody who's going to adopt them that is willing to put in the legwork to have the dog go through the treatments, take them to the vet visits and everything like that, even if it's paid for. It's hard to find. So anyways, What I'm saying is the whole reason your little doggy has to be in that crate for a month to 8 weeks, 4 to 8 weeks, depending. They give them a high dose of ivermectin and then whatever amount of worms, and they don't know how bad the worms are except by symptoms. If your dog is coughing a lot, it probably has a lot of heartworms. It's a sign. And if you guys don't know what coughing sounds like in a dog, it's not anything like it sounds like in a person. It's like whenever you're like, that's a cough. It is, that's a cough in a dog. That's a cough. And so if they're doing that thing where they sound like they're like heaving like air in, that's coughing. So they're doing it a lot and they aren't being treated, they've probably got heartworms. So they look for that. But if they aren't really having any symptoms, if they're able to run around, if they're not a lethargic dog yet, they can have heartworms that could be significant, but probably not end of line heartworms. So you get a dog like that, you give them the ivermectin, they're running around, they're otherwise okay. And now they have to get locked up in their crate because you just killed worms that you can see with your actual eyes inside of dogs, right? You can see it in their little hearts when you hold it up. Like in a jar, I could show you and you would all see the worms. You killed that inside of a dog, maybe the size of meatball, right? Little tiny dogs or big dogs too. And now you've got dead worms in the circulatory system of these dogs. That's why you cannot let your dogs run around after the treatment, because those dogs have to like let their body naturally break up and reabsorb kind of the dead worms, because just like you and me and anything else, things in your bloodstream that are physical things that shouldn't be there can block your arteries and your veins and things and cause embolisms and kill you. So that's why most people don't want to deal with this, because you're not only risking putting in all this time of 6 weeks of your dog only getting to go potty and having me in your crate the entire time because they can't run because you don't want to risk the embolism, but they could die in any time in that period. It's risky. You decide that you feel bad for a little doggy, let's let him run for that day, you might regret it. So it takes dedication. This is Spaghetti and Meatball. You guys got to meet Meatball. And they had heartworms when we adopted them. We adopted them from Pets and People, and they gave us funds they paid for their heartworm treatment as long as we were willing to do it. And I didn't have any problem with that because doggies, okay? And they're cute, look at them. And so Spaghetti, he's cute, look at his little feet. And anyway, so we don't know, probably. Yeah, they probably are, and they're inseparable. And like Spaghetti will lick Meatball's little eyes, and like they're inseparable. Even in this picture, like that's just Spaghetti. But this is Meatball, and you guys met him. He got his little tuxedo on, and he had to point it out with my little pointers. And this tuxedo here, everybody. And that's Spaghetti over there.
Is this on the test?
Right, it should be. So anyway, so yes, so we stuck through the treatments with them. And after they were done with their initial treatment and they were cleared, they wanted us to come back in 6 months and see them again, and they were cleared again. That was about a couple weeks ago or something. And so Meatball and Spaghetti, and Meatball, you saw Meatball, and he's pretty chill. He's pretty good, just like a good dog. Spaghetti, I'm glad we named them what they are, because Spaghetti is like a noodle, because he like does this wiggly thing like his whole body. Anyways, that's my doggies. That's my 2 doggies. Remember, I have a 3rd one, and that's Ripley. I don't talk about her a lot because she's just kind of doesn't really do a lot. She's not super exciting, but she's cute, I promise. So anyways, antivirals, where are we at time-wise? Okay, we're pretty close, but we're almost done. Antivirals obviously kill viruses. You want to either stop them from getting in, prevent them from building their parts, or stop them from getting out of the cell, like budding out, right? So the entry stopping ones, this could be ones that like HIV, and it's the spike, block the spike, it can't get in. Relenza and Tamiflu, they treat the flu. So in case you guys haven't noticed, I'm going to tell you about antivirals, and they basically treat like a virus. That's how specific these are, because we can't target something major about viruses, because how do viruses survive? By using your cell's equipment. So, right? So you have to get pretty specific with them, unfortunately. There are a few that are pretty broad, but not any that are really reliable. So anyways, Relenza and Tamiflu block block, like if you have H1N1, the N stands for neuraminidase. I know we said H was hemagglutinin, but now the N, neuraminidase. ACE enzyme. It's an enzyme that allows them to get into the cell as well as to bud and pinch the little budding off and release themselves.
So is that why they only work like right when you get sick? Like they say within 3 days or something, you need to take it, or it doesn't really?
Yeah, because they'll just
They're
keep like,
already there.
yes, yeah, exactly. Because it's already in the cells multiplying and then it can only do so much. Yeah. It's better if you can block them from getting in. All right, then it will become self-limiting. Then the other one, I don't know where the slide went that I meant to have. I guess I literally deleted the wrong slide and that was probably my fault, but nucleic acid synthesis, the only one you need to know that's related to that is a cyclovir, which isn't even up there, but it is on your study sheet. And a cyclovir might not sound familiar up front, but a cyclovir, let me say another term for it, valcyclovir. Maybe you don't know that directly. What about Valtrex? Maybe you've heard of that. Valtrex is used to treat herpes. Pretty widely well known to treat herpes. You've probably seen a million commercials about it. And it's also the medication that they put inside of the actual like Abreva for cold sores, because cold sores is a herpes virus. So yeah, there you go. Acyclovir is pretty good one to know. Here's our little, all of that. I mean, I have the HIV one. Just be aware that HIV has its own specific parts. We kind of already learned about reverse transcriptase, but those are super unique. And those three are, so we can target those too. You don't need to know the names of the medications. Drug resistance happens usually due to genetic adaptability of these microbes. Intrinsic versus acquired resistance. Acquired makes sense. You got it from somebody. They gave it to you. You were just chilling. They're like, hey, here's this drug resistance. And you're like, cool, thanks. But intrinsic means that if you are sorry, my phone, whenever it does noises, it just throws me off every time. If you are a bacteria that makes streptomycin to keep the other bacteria away, you better be resistant to streptomycin. If you make it, you got to be resistant to it. Okay, shut up, watch. Spontaneous, okay, there's two ways we can get these mutations. You can either just get them randomly. You just have so many bacteria. If I were to say to you, have you guys ever heard the thing about like, there are only like 1 in a billion chance that another planet in the universe is going to have life, LOLZ, or 1 in a trillion or something like that. And then you like actually like look at the universe and how big we know it is and how many planets there likely are in it. And it's like well beyond that. And you're like, oh, well, shit. So you're telling me that. And it's something we don't really like talk about or think about a lot. And we obviously are probably never going to know. That's fine. But I'm fine with that. But it's sort of like this, okay? You have 1 bacteria. How long until it gets to 1 million bacteria? Probably overnight. So if it's a 1 in a million chance, you're going to have a mutation that's advantageous. One night, and you got it. Because they have all of these mutations. They're not as picky as we are, and they divide a lot faster. And they can risk it because if they get a mutation that doesn't work and they don't survive, there's a bunch of other ones that do. So they can risk it. Same with the viruses. So that's usually pretty advantageous for them. Then we have horizontal gene transfer. You guys already know about this one, transformation, picking up the exogenous fragments or plasmids. Transduction, where the bacteriophages, viruses come in and give you the genes as a bacteria and you incorporate it into your genome and you get special abilities. Lysogenic conversion. That was the word for that, remember? And then we have conjugation, the sex pili. There's one other one that we haven't talked about before, and that's transposons. But these are just kinds of genes that can be in a plasmid and then jump out to another plasmid or into the actual chromosome. And so they can jump around like that. Plants can do this too. That's the problem with the GMO stuff. Anyways, the transfers like this are pretty common. Even your own biome can do it. Here's some ways that the drug resistance work. You can either get genes that give you enzymes to inactivate the drug, like break down the drug. You can have, you can stop them, genes that help you stop from getting the drug in. The drug can't get in now. You can have genes that help eliminate the drug. If it does get in, they get these little like channels that can just push it right out as soon as it gets into the cell. You can have genes that, giving less access points or whatever to the drug, so it can't get into the bacteria. There's just not as many there, so it's not as affected. And then they can change their metabolic pathways, like the folic acid pathway, like this one down here at the bottom. Normally they go in a straight line. The drug blocks that B to C, so they just like, forget it, we'll just go around. We'll go the long way. And you guys can imagine how this would work. If you have one bacteria in your whole system that is resistant, and you kill it off with that antibiotic, and that one is left, it's going to grow up. And now suddenly you have a whole bunch that are resistant, and they can potentially spread it to other guys. That's how it works. That makes sense, though. About 70% of antimicrobial prescriptions, especially antibiotics, are given for throat, sinus, lung, and upper respiratory infections. Almost all of them are going to be viral. That should mean something to you. Doctors are just prescribing antibiotics. Oh, you got a sore throat? Here it is. Go take it. You'll be fine. You probably would have been fine if you didn't take anything, but whatever. So they were overprescribing, making it more likely that there will be antimicrobial resistance in other bacteria that we encounter. There's a shotgun approach, which is either throwing multiple antibiotics at something or higher doses than you need. Then there are exporting our antibiotics to other countries who aren't at all caring how they're prescribing it. Hospitals play a part in it too. We've got weak patients that are more likely to get infected, and they're probably also already on antibiotics. So they're more likely to have exposure to these things and become resistant. I know, activity, great. Poor hygiene and PPE practice. So people not washing their hands when they should. People not changing their gloves when they should. And I don't mean that they're doing it deliberately. You just forget once. And forget it once, and you just realize, oh, shit, I was in that room, wasn't I? And you've already touched 10 door handles. So staff right now, because of shit like this, basically 100% of staff in the world, I'm not talking about in hospitals, I mean like in the world, almost 100% of staff in the world is now resistant to at least penicillin. That should be very concerning to everybody because it didn't come that way. All right, another problem, 80% of all antibiotics, let me say it again, 80% of all antibiotics in the United States are given to livestock who are not sick. This should not surprise anybody. You guys know anything about the livestock industry, this should not surprise anybody. They say, oh, better meat quality, oh, better animal health, oh, bigger size of the animals. It's going to happen, whatever. But they also have bacteria, and they can become resistant to those antibiotics and then spread those genes to us. That is ridiculous. Uncalled for. All right, so this gets us into this concept of the post-antibiotic era, which is just saying that like at some point we're not going to have, like antibiotics are just not going to work enough, right? You're going to have diseases that cannot be treated. These are the ones that we're most concerned about, things that are carbapenem resistant already. And then ones that are just overall extremely resistant. This is the urgent threats. These are the ones that are the absolute most serious. You notice that MRSA ain't on here? This is what I'm saying to you when I tell you that MRSA is not anywhere near as big of a deal as you think it is. But what I'm saying is you think it's a big deal, you're right. You don't know the worst of it. That's what I'm saying. There's way worse out there. Anyways, so C. diff is on this list just because. Okay. And then we have down here, this is the one that I've mentioned before, gonorrhea. This is completely resistant to drug treatment now. Not every strain out there, but there are quite a few strains. I mean, quite a few. In quite a few places now, we're seeing strains pop up kind of regularly that are entirely, completely untreatable with antibiotics that we have. And I have no hope of that ever happening. This exists. This is real life. That is scary. This is where it's going. It is. And so we have completely untreatable gonorrhea. You come into the hospital, you get treated, you get diagnosed with this type of gonorrhea. And what are they going to do? They're going to say, well, hope you use condoms. That's it. That's what you get. Because there's nothing they can do. There really isn't anything. People will be like, well, what about another drug? There aren't. That's it. That is it. So anyways, there's other ones on here. You're welcome to look through the list, but down here, this is where MRSA is. Cool. So we either need to make new drugs or custom design new drugs, find new drugs, whatever, but they'll just get resistant to that too. So probably better is these new approaches using nanomaterials, antisense RNAs, CRISPR, bacteriophages, and things for just specifically things on that gram negative that they have to have on their cells to exist. We target that. So that's the idea. If you want to help out your body with all of this, take probiotics. I mean, this isn't a joke. Like some people think that this is just like overplayed. Oh, sure, you know, the probiotics, whatever. They work. They are good for you. If you, yes, eat your yogurt, take your probiotic pills. I take a probiotic pill with digestive enzymes and fiber. I'm getting old, y'all. When you get older, you will see the value in some fiber, I tell you. But I take fiber and digestive enzymes with probiotic at every meal because I'm old. But I promise if you ever have any GI troubles, that will probably be like, you'll just trust me, it works.
Every single cancer reduction thing says eat more fiber.
Yeah.
One kind of cancer.
I'm not kidding.
Like, okay, well,
It made a massive difference in like I'm not kidding. It just really helped a lot. So get more fiber. But yeah, it'll replace your microbes that you've lost for antibiotics or supplement the existing ones. Prebiotics help feed the good guys. And then of course we have fecal transplants. I know it sounds so gross. Yes, but sometimes if you're going to treat C. diff, it's really hard to treat it. So a lot of times you can't get it treated in the first couple of tries. You just have to take enough antibiotics to just clear out your whole biome. And then they will put someone else's poop into basically your butt. Okay, it'll be a colonoscopy. You won't know, I promise. But yeah, that's how they do it. That's how they colonize your guts. And if you have C. diff, you will be thankful for it. So,
isn't it like someone who lives with you is most likely to be the?
yeah, it's usually they want somebody that lives really close to you because you're gonna share their, biome anyways. It's more likely to take it. But anyways, you have to have a biome. So this was, of course, I got really lazy on this one, but these were my terms that I wrote down. And as bad as this looked, I ended up reorganizing it. This is my entire study sheet for this whole thing. So I could see it in sections like that.
Both look beautiful. They're better than what I. Right. I don't see
Right.
what problem is.
So if you guys, take your time, and you're welcome to look at mine and use them as inspiration, but I highly encourage you guys to make your own, even if you use mine as a template. Okay, at least start working on it and think about it that way. But that's it. Let's go to lab and get this out of the way. Sorry for talking about meatball and stuff for so long.